Welcome, everyone, and thanks for listening. Or if you're watching on YouTube, thanks for watching and listening to Sports Doc Talk. I'm Will Sanchez along with Dr. Grant Garcia. Dr. Garcia, what is this? It's just a party of two. Normally, we've been having all these great guests, and today we get a chance to catch up, do a one-on-one, and really kind of do a topic that is near and dear to your heart. How are you, Dr. Garcia?
I'm good. We've had, like you said, so many good guests, but, it's time for us just to hang out. We haven't done this in a while. We used to do this pretty much all the time. And we've had some phenomenal guests. People are getting tired of just hearing me and you talk all the time, but I think it's time for us to get a little bit more FaceTime. So this is good. This topic, while near and dear to my heart, and we get lots of patients asking about it, it was actually a patient request. So we had someone go through the website. You've seen we've had a couple of those we've presented on recently since we've had the new Sports Doc Talk website. And, the patient's actually, it's actually a patient of mine, but they went separately through the website to ask this question. And I thought it was really good because especially the patients for me, we see a lot of local patients. We have patients that drive 3 or 4 hours. And then we have patients, and this patient's actually from out of the state. And so they'll come from out of the state and they want something different, right? Like they don't want to fly up for surgery and say, hey, listen, I want to go fly to you. You do a decent ACL or whatever, but they want to know, like, is there anything else you can do? And in some cases there is, sometimes there isn't, but they want to ask those questions, right? Because they feel like there's more out there. They've done research, they've done Dr. Google, which we know is never the best thing. But it does help in some aspects, because I think the problem you have is you don't always know what you don't know, and you don't know what the surgeon doesn't want you to know, or you don't know what's available and what options are. We've already seen different ways of doing ACLs. We've seen different ways of doing ACL repairs. I mean, even in the city of Seattle, if you went to 3 different doctors, 2 of them may never even bring up the word repair. Yeah. And so it's important for people to have all these information. It's also why it's important for second opinions. But I think the point here is biologics is in its infancy, and it also matters about how you ask the right questions. So the thought is, they've heard about the repairs. They've heard about Bear. Yeah. They've heard about ACLs injuries. They've read about this thing called BioACL, which we'll get into in a minute. And we've actually talked about it on this show, just a different name. Yeah. You've heard about bone marrow, you've heard about PRP. So we're going to talk about, like, how does it all integrate together and kind of work our way down from the basics to more complex. And hopefully the listeners will learn a little bit on the way. So.
Yeah, it's like we said, it's right up your alley, and talking about our ACL injury surgery and biologics event. And as we get in, right before we get into that, though, I'm kind of backtracking a little bit here. We're 6 months into the new year, and we had Dr. Acevedo and Bashai and Dr. Jazayeri, and with his peptides and different techniques, and whether it's Leah Winter, which was at the end of 2023 before we started 2024, just kind of reflecting already just the tremendous amount of shows. And we have some great guests lined up as we, oh my God, head into the summer. And next thing you know, it'll be fall again, and the kids are off to another grade. But I'm getting ahead of myself. So let me just kind of slow down a little bit. But I think it's just a great reflection to just to thank the audience members, to thank our guests that have listened, watched, and been a part of the show, that have reached out, that want to have these conversations. And we just want to thank you. And whether you're watching us on YouTube, check us out on Spotify or Apple or any of your favorite platforms. So I'm just giving a quick, tip of the hat. And if you're watching right now, I'm tipping my little hat right over to all the fans and guests, and just thank them. Anything that you want to add there before we get into talking about ACLs without surgery and all this good stuff?
Yeah. So, I mean, it's just, the guests have been phenomenal. We have more to come. I think one thing I've heard a lot from other orthopedic surgeons I've talked to, or other people in the industry, medical device companies, et cetera. What they like, I think, most about the podcast, which we didn't think about originally, was, while it's all sports, all orthopedics, that doesn't always mean surgery. So we're talking about innovation, nutrition, talking about how other people deal with interpersonal stuff. I mean, Acevedo and Bashai are 2 of some of the best surgeons I know, and they didn't spend most of their time not even talking about the surgeries, right? We talked about how you prep for surgery, all the behind the scenes stuff. I mean, this show is keeping it real. You've heard so much stuff that you will not hear on many places, and getting to hear how it works behind the scenes. We had the tech the tech show, obviously with us,
Yep.
that's, it seems people don't even hear about that stuff, right? You maybe hear it at a cocktail party if you happen to run in and be with a surgeon. They've had a few drinks, maybe they'll tell you the truth. But the thing is, it's really exciting, and there's more to come, and you're going to see other things that you're not expecting, right? Other guests that are not surgeons, right? That are going to come in and they're going to have topics that are important for orthopedics or sports, but maybe not always surgery involved. So anyhow, we're getting off topic again, like we always do, and we're trying to keep.
Of course we do. That's okay. It's part of what we do. But going back, hey, check out the Tech Trends Unveiled. That was a great episode. And let's give a shout out to Dr. Schaefer, right? He was another guest that we had
There
on.
we go.
Just so many. So if we forgot anybody, we're always thinking about you. But right now, we're just, kind of jumping around. But let's talk about this ACL injuries, surgeries, and biologics. And the first thing when you sent your notes over to me was like you mentioned to start the show. This was a request. This was someone that wanted more information about it. So when we talk about ACL injuries that heal without surgery, can you start with like primary repair? Like what does that entail when you think about or when you're discussing primary repair when it comes to these ACL injuries?
Perfect. So we'll go one step back further. So there's
Sure.
a lot of hype. You may have seen the articles. You're looking at your Apple News and you see ACL repaired without surgery. Magic, right? They'll get like 200 MRIs. It's usually a European study. And no offense, to the Europeans, but they tend to have, it tends to be different data sets, at least for some of these things.
Yeah.
And it's in a journal you've never heard of. And they're saying, hey, they repaired all these ACLs. You got to be really careful about this, because as someone that does a lot of ACL repairs now, when I get in there, I pretty much have never been in one where I get in there and all of a sudden the ACL's completely stuck to the wall and I don't have to do anything. You just kind of attach it like we talked about with the tightrope and it goes back. I had one last week and I said, there's absolutely no way this would heal on its own. These ACLs, they retract. Imagine like recoil, right? There's a springiness to the ligament. And so when they tear, they recoil. So while they're still stuck on the wall of the femur, they're pulled back. And when you stretch them out and retighten them, it's amazing to see how they go right back into the orientation of when you see a normal ACL. Because we do a lot of surgeries on people that have normal ACLs for other reasons. And we know what it looks like anatomically to be normal. And so you got to be really careful, because the idea of it healing is not the case. Now, maybe in patients with partial ACLs, so that's a different topic, and we're not going to go too much into it. But partial ACLs or sprains are actually fairly common too. We see probably, I would say maybe one out of every 10 ACLs I see is a sprain. Now, again, I'm seeing more surgical ACLs. It's a bias to come to the surgeon with a surgery ACL. Yeah. But people that sprain their ACLs, we see a lot, especially my team, Tim, the teams I cover and everything, because they're coming to me regardless of whether it needs surgery. These partial ACLs where it's like either a partial bundle or it's just a little bit of a stretch, those are ones that sometimes can get away without surgery. And I tell patients maybe 30, 40% of patients may need surgery at some point. And sometimes it's lower, you never know. It depends on the amount of injury. And that's where biologics, such as potentially PRP, which is where we take your blood and spin it down, or bone marrow, where we take bone marrow out, may be helpful. Again, we don't have a lot of data on it. They've looked at ACLs and PRPs for sprains. And the data does show that some studies show there may be some slight benefit and others show nothing at all. So it's something to be aware of. Now, doing PRP when you acutely injure it, there's no downside. We'll talk about these biologics. There's no downside to the biologics except for the cost. They're not covered by insurance.
For folks like me, it's the platelet-rich plasma, which is the PRP. So if anyone's listening doesn't know what Dr. Garcia is mentioning, like myself, as I'm just a doctor on the radio here, but platelet-rich plasma for the PRP people out there. So I'm sorry to interrupt, Dr. Garcia. Go ahead.
No, that's perfect, and that's a good segue. It's important to mention that. So anyhow, so the PRP or the platelet-rich plasma, the bone marrow aspirate, which is from your bone marrow, like your hip, your knee. We can take it from all different places, and the idea is in the acute phase, you give that to somebody and maybe they'll help them heal. Now, like I said before, data's mixed. So that's on the non-surgical, maybe biologics options. And that's something that people can try. And again, there's no downside except for the cost. So, depends on the place you go. But there is a cost to these things and they're not covered by insurance. So people have to be aware of that. So, that does change the aspect. And that's important to bring up. It's just like the tech trends. All these sexy biologics we're going to talk about, they are not covered by insurance. And
Yeah.
it's different than like implants. So like if you have an implant, it's all bundled in the price, right? So you can basically, like, sometimes it's more expensive and it's something that it can't be done because it's just too expensive. The surgery won't cover it. Your insurance won't cover it. And there's no way to get around that. With biologics, it's never covered by insurance. And there's no way to get around it getting covered by insurance because basically they're expensive to do. And so the patient has to be on the patient's onus to do it. So understanding all this stuff sounds really great when it comes to the biologic side, but people who ever get these are paying out of pocket extra for them. And it does, yeah.
Real quick, is that something also that the insurance can find a way to excuse, saying you don't really need this, or you might not need this? We can treat this differently. It may not be at the level of biologics, but fine, we can put a Band-Aid on it. It might not be the nice ace wrap band to hold it together, but it still is effective. Is that their way of kind of working around, paying for some of these things?
Yeah, so we still use codes, like I told you before.
Yeah.
For these biologics, there's a PRP code, there's a bone marrow aspirate code, but they're considered experimental. And don't get scared by the word experimental because it doesn't mean you're being experimented on and no one's ever done this before. It just means that's the insurance company's way of saying we're never paying for this. There's not enough. And the good news for you is you can actually pay for it because in some of these things, yeah, but we've talked about some of the implants. They're so expensive that, and the insurance company will never pay for them. But by contractual rules, you're not allowed to pay extra. So then you're just stuck. You just never get it.
Yeah.
Versus this, at least you can get off. There's no contractual rules that you can do it. So that's the one thing. And they're really safe. I mean, there's no downside, like I said, to most of these things, except for the cost. We're getting sidetracked on that, but just to let patients hear this, but that's how it works. But basically talk about repair. So, we talked about this before and you could bring it up, my favorite, which is the tightrope repair, for ACL. So let's say you decide you want biologics, or you're like, hey, I want a biologics and I need my ACL fixed. Well, obviously in one of our requests was, how do you save proprioception? So the idea behind the repair, we've brought about this about 1 million times now in this podcast, is that if you save the ACL, these patients, I'll tell you, I've done a lot of these. I'm up to like 40 or more. We just flew down to San Diego to teach about this. So, this is a hot topic. We fix them with this device, and when it goes on to heal, their knee feels better because the proprioceptive things are saved, right? When we do a reconstruction, we're removing all of that, or a lot of it. As much as the doctor tells you to try to save as much, you can't really do a good ACL reconstruction by keeping the entire ACL there. So the idea is you're saving some of the proprioceptive receptors, which is important for certain people, if it heals. And then, there's less stuff that comes out. You're not making a big bone tunnels, and there's less pain. The patients are doing a lot. They're feeling different. That being said, not everybody's a candidate, like I brought up before. Yeah. I would say I do a lot of ACLs, so I'm probably done, if I'm doing probably one every 6 or 7. Now my indications keep getting a little bit broader as I do more of these, and I see, okay, this group is doing really well. Yeah. I'm going to broaden a bit more. This group's doing really well. And I'm going to keep going slowly. So I do this appropriately. Because again, I told patients before, I'm not here to experiment, but I want to give them the cutting edge stuff. So what people don't understand is they always ask, they ask for biologics with this too. They're like, hey, what else can I do? Like ACL repair, that's great. Like that's old news, right? We're on to new stuff. What's the newest thing you can do? Well, what they don't realize, and you can bring up the little pick device, is that every time we do a repair, whether it's a bear, an ACL repair with the tightrope, a combination of both, we'll get into that in a second, we use this device. This is a power pick. There's other ways of doing this too. And basically what we do is we make little holes in the bone where the ACL and the PCL sit. And we actually do this for meniscus tears as well. And this brings bone marrow in. So it's actually covered by insurance, this procedure. So that actually is nice for patients because they're not paying out of pocket for the PRP, which is the platelet-rich plasma, or the bone marrow. And there are people that are looking at whether we can add more biologics. Can we add bone marrow, which you don't always get from just this alone, that's concentrated, or platelet-rich plasma that's concentrated. And it's the same thing they've looked at with meniscus tears. Again, it's hard to show a big difference because this microfracture thing causes improved healing as it is. So it's hard to show something that's as effective as this and biologics being better. Does that make sense?
Yeah, I guess my question is, this tool is creating the holes, right? And
Correct.
then what do you mean that it's promoting bone marrow? When you
So you'll
say that?
see, and we don't have a video to show you, but when I do this, you see
Yeah.
fat bone marrow coming out as you're doing it.
And
And so
by
the idea
creating
is,
the
and again,
holes, now it's going in and then doing its
coming
own,
out,
it's coming out.
coming out.
Okay.
So you're essentially going out into the knee. And what it does actually simulates an ACL tear, because we've seen when you tear your meniscus and then you tear your ACL at the same time
Mhm.
and you do the surgery at the same time, they
Yeah.
heal way higher rates than if it's just meniscus alone. So you want to simulate this ACL tear. Um, and even if you don't, when you do a reconstruction or you need a repair, you're not making as big of tunnels, you're not doing as much trauma. And so as a result, you want to still simulate this ACL, you know, fluid stuff coming in so people will heal.
So how does that
And this gets,
affect your recovery by doing this procedure? Like you're adding this, lack of a better word, kind of like simulating this injury in order to promote healing.
that's a perfect example. So I tell patients sometimes they'll have little bit more swelling in the first few weeks, but we also have tricks to reduce the swelling that we give patients medicine called TXA. So it's negligible. The problem is, if I have something that's going to increase your success rates by 25% for a meniscus,
Yeah.
it's pretty hard for me not wanting to do that, regardless if you feel swollen for 2 more weeks, right? Like any patient, any person would say, I would want that. I want to heal better with the first time you try it than dealing with swelling for 2 or 3 more weeks. So
That's it.
that's really
You
that's
see
the
what you
downside
Yeah.
of doing this. It's pretty low. Um, but people are looking at this. I mean, we're looking at this. I work with the Arthrex company. You've probably seen a lot of my stuff.
Yeah.
We're looking at finding ways to add more biologics. They're talking about putting collagen patches on to help the ACL heal. And so we're getting there. And one of the ones that does this is Bear. Let's bring that up too. Like we've talked about this before. The thing with the Bear here is people don't get is that they think the Bear is the entire surgery. And we just posted our newest video. We actually use the Arthrex ACL tightrope, and then all we do at the end is slide the Bear down there and add it. So the way that was FDA approved was a different type of technique, and we continue to improve this. If you look online, there's like 20 now videos out. All these are the top guys doing Bear ACLs, and each one of them does something different. So it's just wild because the idea of Bear is literally just the implant. All it is the collagen implant soaked in whole blood and put into the knee. And then everything else, they don't really like, it's really not a step for doing that. Like the old technique, the FDA approved, that's great, but it's not as strong in my opinion. And so that's why I started doing the tightrope with them. And then I'll add the Bear, like I just did one a few weeks ago. And so what we're seeing with that is that you're hopefully going to have, you get the ACL to hold up to the wall, and then the Bear implant, which is this collagen with, the whole blood. People are actually using PRP sometimes. And as soon as, how this works, as soon as it hits the market, you have all these like smart surgeons that are like trying to figure out a better way to make it better. And they're all trying to tinker a little bit because they want to find the golden ticket, like which one's going to be even better than what's currently out there.
Yep.
Right.
Yeah.
And
yeah.
it's, I hate to say the word off label because not really, because there's really not a label for how you should do this. Like there's a technique guide, but the FDA doesn't say you have to do it this way. They just want you to make sure you have to do a certain things that are allowed, which is like, soak the blood, put it in the knee,
lay the groundwork down, and then it's up to if you're going to be a little creative or what works for you. And then I'm going to oversimplify it for people that are listening to the show. They may not really understand. Think of you having a hole in the wall, right? And then you're creating this compound, right? And or stucco, and you're covering the hole in order for it then to harden and heal correctly. And this is kind of what this Bear implant, this bridge enhanced ACL repair is kind of happening. Obviously, I'm dumbing it down here, and not to take anything away from it, but it just kind of gives you a visual idea of what this compound or silly putty, whatever you want to call it, that's kind of holding everything together so it can heal correctly, right? Am I wrong in that assessment there?
You're pretty good on that. I mean, we brought this up before, but like the MCL, which is the ligament on the outside of your knee, almost never needs surgery. And so what they're doing is trying to turn this into an MCL tear. So ACLs used to never heal. That's the thought process.
Yeah.
And now we're doing more repairs. The Bear's out. People are doing more Bears. And the idea is that basically it causes clot that guides it to heal in a very, we've heard of the word collagen impregnated. Everything's collagen impregnated.
Yeah. Yeah.
right? What about UCL internal brace? We talked about this from
Yep.
Brock
Yep.
Purdy and the throwing. Collagen impregnated suture. Well, in this, the FDA didn't have the internal brace. So now I do an internal brace, I do a tightrope, and then I add the bear at the end.
Colonel
The thing you're trying to
Brain.
ask yourself, the thing you're trying to ask yourself is, wait a second, you're doing an ACL tightrope, which is identical to the other surgery you're talking about, and all you do for the bear is just add the bear. And
Yeah.
the answer is yes. So the problem is there's no head-to-head studies at this point because is it the bear? Is it both? What is causing this improvement, healing, or your patients doing well?
So
And
there's no study
yeah,
right now saying, and this is all right. I'm going off track. I
I
apologize here.
like it. No, this is good. I'm talking too much. I want to hear your
No,
questions.
no, it's fine. uh, when you do a surgery and you say, okay, I did the bear, I did the tightrope, I did, whatever I'm doing, and then I say I did these three different techniques for this. That's not going into some kind of database. Then you can have the recovery time, the patient. This was what happened, and it goes into a national database where everybody's now kind of keeping track and or some kind of form. Is there nothing out there like that where instead of the FDA just kind of doing their own studies, but the surgeons themselves that are putting in the combination. Well, I only did the bear and I did the tightrope, or I only did the tightrope for this one. And then you're seeing those comparisons based on the severity of the injury.
Oh man, you were opening up a can of worms. I love it.
So,
Well put. No, it's great. So, first off, those studies are expensive, right? So who's going to pay for them, right? Like, are you going to have the surgeon
Excel
say, "Hey, you're going to"?
spreadsheet, Google Docs,
It's not. No, because you got to get permission for the
HIPAA,
patients, right?
right?
Like, it's not
HIPAA.
like I can just throw in HIPAA.
Yeah,
Now,
HIPAA.
technically, I mean, technically, a study where no patient's information is given out is okay, but
What
that's really
about
hard to do
within
because
your office, right? Or your doctors or
still
something?
has to be
Still can't do
approved.
it.
Still has to
So
be approved. I can't
who
start
approved that?
logging a spreadsheet like a whole there's like a committee that has to like look at this and
I'm
then
going
say
to
like
talk to the
is this
committee.
legal?
Can you take me to your next conference? I've got a
I
couple in
will. I
Harrisburg.
will. So basically, we're gonna try not to get too off topic here, but basically the idea is it costs a lot of money to keep systems to do that, and we're getting there.
Yeah.
Bayer has their own reps, the people that bring the implant in. They ask questions about the surgery, like how old was the patient, when did they get injured, how they choose you. They ask all those questions. They keep track of it, and every 6 months, I get a message from them with the entire national information, and it's all confidential at this point because they want to publish it and make it peer reviewed and fully reviewed and checked out.
Okay.
But yes, the answer is it's really hard to do all these in certain places. I'm private practice, so I don't have a lot of research assistants. I don't have fellows, but a lot of places I've worked, HSS and Rush, they're machines. So they would have someone in the OR like writing everything down. Patient, when they sign 15 consent forms, one of them is the IRB, so we're allowed to keep their information and follow it. So yeah, I mean, you can track it you can track it afterwards. We can look up codes and stuff of patients, and I've done that before. And then you can call them 2 or 3 years later and see how they're doing. So we're going to get there. We're just not there yet. And this stuff's so new. But you're going to see more things coming out of the pipeline. But imagine surgery comes out, you need at least 1-2 years, if not 3 years after the surgery, because you got to make sure enough of the surgeries have been done. So we're just not there yet. But this comparative study is a really interesting one. And it's something that some of the companies are thinking about. So one of the things they've been doing with the bear is actually grinding it down into because you may have seen it's like this big honking piece of collagen, and then you put stuff on it, and then it starts to get gooey, and you put it in the knee. Some guys are grinding it down, soaking it with stuff, and then just squirting in the knee. So it doesn't. We're finding other ways to deliver it too, and that's another maybe off label, but that's a biologic thing. Is like, is it just the? It doesn't have to be the actual implant size. Is it just the stuff in the knee that you can get in there?
Okay, and it's always going to be kind of like a silly putty, right? You're never going to throw it into like a NutriBullet and grind it up and then sprinkle it in there and do some kind of concoction.
You never know. You never know. And one of these questions we always have is, can we do? How do we keep it in there? So the word collagen, like a lot of these different things we talk about, they have something that brings it in. It's a conduit. So that's the idea behind this collagen thing. Is it can soak up the blood, and then it starts to create clot formation. And yeah, everything's about conduits. Like if you just push stuff in the knee, it just like floats around and disappears, right? Like the idea is like, that's great. But with some of these things, you want a delivery system. And so that's where this becomes challenging, because then you start talking about manipulating biologics, and then that technically is FDA. Oh, geez. Put some balloons on there. That's exciting. So manipulating, you want to be careful. So you gotta stay within.
I think
you got to stay within your limits. I definitely think they put the balloon. Anyhow, so that's it for the ACL repair and biologics.
Oh, that was perfect.
Let's see if I can do it. Will it work? I'll try one more time. Air quotes is not working. Maybe we'll get later.
I think everything is better. That we should end every segment with balloons. So that I think that is perfect. No, it's fascinating to think about that, and it was interesting because you obviously you made the point that you needed to stay, not just put it in there, but to stay, because my first visualization of when I was making the joke about grinding it up in NutriBullet is like, if you ever had a wound and you put salt in the wound, you see it bubble up, right? And it starts to, obviously it's painful and things like that, but it bubbles up and kind of kills everything. You see everything kind of happening. I was just having this vision of you sprinkling this concoction into, the knee, and who knows what works. But anyway, we get sidetracked. Let's move on. I know we were talking about the key components, benefits of the bare implants and the ACL, and you wanted to jump into ACL grafts and things like that.
Yeah, I mean, so one of the listener patient, he's already had an ACL done, so he wants to know more about the graft options, right? Because the repair is sexy, but there's a lot of ACLs that are done and people have an injury again. They want to know what to do after it, right? Or there's people that can't get their ACL repaired, right? Like the idea of the ACL repair is very sexy, it's very cool, but it's not for everybody. I mean, it's like less than 10% of patients, and so it's just most patients are never going to have that option.
Wow, and I did not realize 10%. Why is that?
There's some people pushing the envelope, but it's really the certain pattern of tear. It's got to be torn off the femur. If you look at it, I can't remember the exact data, but it's like maybe 10, 20%. And maybe we should be repairing a few more of these, and we're starting to get better at it. But, I'm a surgeon that pushes the limit. I do probably the most repairs in Seattle, if not the whole area. I teach on this, and I'm still not comfortable trying to repair all these ACLs. It's just,
but you're a proponent of rehabilitation anyway, also.
Yes. And I'm a proponent of all these things. I'm a proponent of reconstructions. I'm a proponent of all these things. It's just
depending on what the need is.
It's important for the listeners to understand. So I think the important thing you should understand is it's not just like adding biologics and doing. So let's move on to the ACL reconstruction, because that's actually the more common thing.
Yeah.
So, let's say your surgeon doesn't want to repair it, or it's not a repairable tear. Well, majority of them get reconstructions. And when you get a reconstruction, there's three things you got to figure out a way to improve if you want to get someone back faster. So like all of this is like, people have to do this. People are worried about their graft healing. Like the grafts will heal. It's just a question of how long it takes. And so that's the thing that I think people are worried. They think that if they're going to get biologics, that they're going to heal way better than anybody else. And then they're going to get back faster, or they're going to get back and have a stronger ACL. That's not the case here. There's some things we'll talk about that may add some structural integrity to it, which we've mentioned before.
Yeah.
But really it's about speed, right? Like if I could do an ACL on you, the reason people want the ACL repair is it's faster recovery. Not the bare, you got to follow the protocol, but the repair tightrope, people are back faster. And so that's why they choose it. I mean, I'll offer it. It's like 95% of people. So this fertilized ACL is a perfect point, but you want the graft to heal to the bone faster. So it depends on the graft option. You've got patella tendon, which is bone. So that'll heal versus other tendon options, which is what the fertilized ACL is. And then remember, you're taking a tendon out, which is a tendon is a bone to muscle attachment. So you've got the hamstring tendon, you have the quad tendon. There's a few other options too, but you want to make it into a ligament. So a ligament is where it's attached to bone on both sides. And so it's got to go a process where it goes ligamentization, where it basically turns into a ligament. And then you want to make sure it doesn't tear as it's getting bigger and better. And so the idea is that if you can make it heal faster, and you can make it remodel faster, and you can keep it safe and stable, then you've come up with the perfect solution. And so the idea behind this fertilized ACL, which we've heard about it, you actually we talked about it, and then actually was a couple of years ago, and then Chad Lavender reached out to you. And you had a whole topic with him. And so, maybe we'll have you be a great guest to have on at some point. Now we've
Yeah,
had
yeah.
this,
Adam
this
Marshall,
new one.
he's a yeah, and he's a sports guy too, so it'll be interesting. Maybe he might be a good one for the fall as we get into football season. He'll be
For
excited about
sure,
that
for
college
sure. I think I
football.
added them to the list. This would be
Yeah, yeah,
great. So typical ACL, 9 months to a year to get back. And so what Dr. Chad Lavender has done is something called the fertilized ACL. And actually my patient asked about this. It's called for Arthrex company itself, it's called BioACL. It's the same basic principle. And so what they do is they take PRP or your own blood and they put it with allograft bone. It's called mineral bone tick. So the key is to hopefully it's a conduit, so it's like soaks it up, and then they inject it into the tunnels, and then they can take some of your own bone. So they have this device that as you shave, it sucks bone up and it filters it. Imagine like a pool filter. And so the bone's all mixed up there. It's your own bone with some other bone, and then the PRP, and then you can inject it in the tunnels. And what he is trying to show is that patients will get the bone to tendon healing faster, and then potentially the ligament is faster, and so therefore they can get back faster. So he has looked at some studies and shown some patients that have gotten back at 6 months with this. Now the caveat, which if you look at the studies, and I know we've done some of these, is he's had some trials where he's had really good results, but some of the trials, not all the patients came back for the follow-up. And so you've got to be a little careful, right? Because who's the most likely patient not to come back to a follow-up?
I don't know. Would it be a young
Probably
person?
someone who's not happy, right? If you're going to get called and all of a sudden in
Yeah.
2 years.
Yeah.
So it's not that his data is not accurate. I think it's awesome what he's doing. I'm all for it. And I think it's legitimate, but when you start losing follow-up at 2 to 3 years, you have to say, hey, listen, are all of these patients, did you lose follow-up because they left the state? And that's totally legitimate. And that happens all the time. Like it's really hard to find, if you're doing surgeon people and they're flying in for surgery, that they're going to call you back or pick up the phone, right? So it doesn't mean that. You just have to have a little bit of a healthy bias or a healthy skepticism and say, hey, listen, this is pretty awesome what they're doing. They are getting patients back. I mean, I've seen promos for this. It's pretty impressive. And these patients, we talked about this, their return to sport function, they're 80% of normal compared to 35% for regular ACL.
Yeah.
Their functional tests, they're 80% of the 30%. And their CT scans, which is CAT scan, where you look at bone, show that they had less tunnel widening and they're already starting to form bone around the quad tendon. Now, again, this is only for one type of ACL, which is quad, which is where you take a piece of your quad. It's not for patella tendon and it's not for hamstring, which are actually way more commonly done ACLs. And so it's something to be aware of too. It's only been tested on one type of ACL. So there's a lot of caveats to this, but it's really cool because he's addressed everything that we're concerned about. And he's pushing the envelope because no one's willing to do this. I mean, he's letting these guys rip. I mean, he's releasing them to full activity at 6 months. And that's terrifying because if you have a kid tear their ACL at 6 months after you let them go inadvertently, that's really traumatizing, right? And he's a surgeon. I mean, as a private practice surgeon, I don't know if I could get away with that. Like I have to see some data before I did it, just because patients would immediately tell everyone, my surgeon let me go at 5 months, and they'd say he's crazy, right? Yeah. And like the ACL repair, I had to slowly integrate it in, and I had to see how the first patient did, second patient. Okay, I'm going to let more and more do it. And he obviously has gone for the gusto. So I have only utmost respect for someone like that. It's something that patients should be aware of. So this is a biologic option. So we do your ACL, we add either bone marrow or PRP, one or the other. And then we do this putty, which helps grow it in faster. And it's a little bit technically challenging too. And the idea is you do it all, but it doesn't go inside the knee, right? It just stays in the tunnels. So, and there's a certain way they do it too. It's a different technique than some of us do for the ACL. So you got to do everything exactly as a study, or you're technically not following the protocol. Yeah. Does that make sense? Yeah. So it's really good. I mean, it'd be nice that this needs to be expanded. Basically, it needs to be expanded for other surgeons, because I haven't seen, when I was looking up for this show, I looked up fertilized ACL or bio ACL, and he's the only one that's published about it. And so it would really be nice to see someone else who didn't invent the technique showing good study results as well. So there's a lot more work to be done, but this is something really interesting for patients, and it's definitely a viable option. I think it's totally legitimate. I just would want to see more information.
Yeah, I mean, it's really interesting, and just to think about, we were thinking about this this mix that we've been talking about for a while now, and how does that evolve, right? Does that keep evolving to, finding the right mixture, and whether it's holding, not holding, soft or harder, like how that affects certain things. But obviously, you do test on cadavers and things like that. Is there a way to kind of expanding on this quote unquote kind of silly putty that you're utilizing to fill in the gaps on, just cadavers, or do eventually you need to have, real folks to get real data going forward if you're doing different mixtures? Kind of a little bit of the
So
Frankenstein conversation right now.
yeah, I mean, the nice thing about this is that none of these things are dangerous they're doing,
Yeah.
other than like, the idea of dangerous is like, something that's not approved for patients. But all this
Yeah.
stuff like the putty, the PRP,
Yeah.
everything I talked
I'm
about, we put that
mixed.
in knee all the time. I did 2 of these today. Like I added putty and I added PRP in patients today. Like
I
it's
love that. I
totally
got you saying
legitimate.
putty too. You're gonna be saying putty to everybody.
No, but it's called, we actually call it, I go open the putty, right? It looks
Okay.
like putty. It looks like putty.
It looks
So
it.
all of these things we're already doing in the knee all the time. And so what he did is found a concoction that works for him. He kept it regimented. He
Yeah.
documented it. And then he looked to push it to the next level. And he did everything right. He had MRIs, CT scans, watched the players getting ready. The one thing that you got to understand though is they probably had really good physical therapy and probably therapists that were willing to let them rip. Right. That is
Dang, you stole
incredibly
my
important.
thunder. I was about to say that. Oh,
No, keep
damn it.
going. No, you know
No,
what I'm
that's
talking about
exactly.
here.
That's exactly what I was going to ask you. I was like, wait a minute. This all tells me, in order for him to say, "Hey, 6 months, go," what kind of physical therapy are they getting? Is it once a week, or they're in their, mandatory how many days, right? So that's even the bigger conversation now, besides the surgery, is right, because we talk about it, right? Hand in hand. Your physical therapist, the homework when you go home. How much are you working? How much are you doing? What's the requirement if you have this type of surgery? You want to get back in 6 months? Well, you're seeing your physical therapist 3 times a week. So, these are, questions that you would like to know, besides the procedure. What's really going into it? What's the Molotov cocktail in order for you to have success?
I think it's a perfect point. And I mean, remember, I do ACL repairs. My patients still come in slow sometimes because the PTs are so nervous. They've never seen this protocol before. So
Mm,
like these are probably finely tuned for the clinical trial, right? They saw the
yeah.
same therapist who did all of these. And so that's where you got to be careful. Can you extrapolate this general population? I mean, if I'm operating on, I have a patient, she flew in from Montana for an ACL repair. Like I have no way of dealing with her physical therapist in Montana. Right. We have patients that come in. I have to have a surgery that they can follow my protocol, but they're still nervous. I mean, even some of my regular ACLs, if I'm more advanced than some other surgeons or I do something differently, they still want to keep it their own way because they're nervous. Because they don't want to be responsible. They feel responsible. The person tears their ACL too at 6 months to a year.
Are you doing video calls for out-of-state folks after post-op?
I usually will just do phone calls. The video I find doesn't add a lot of value except for just looking each other in the camera. And it's really hard because I can't just FaceTime them because of HIPAA. So I have to use like a program.
Oh,
And
okay.
so then if you have to schedule it, we used to do video calls during the pandemic and we've stopped because it's really hard to schedule stuff for patients because they want to be called at a certain time. But if you have time in the middle of the day, so we usually just do phone calls out of state and it works perfectly fine. If a patient
Yeah.
wants a video call, I'm happy to arrange it. But usually, I mean, most of the time you're just talking to the doctor.
Gotcha. All right, let's move on because I'll sidetrack you continuously here.
Yeah. So let's put up that slide to look at the growth factors. So we talked about this is with reconstruction. The fertilized ACL is the best example we have for biologics. So it's important, again, we brought this up and we can throw this off in a second. Everything we're looking at is called autologous, which means it's from your own body. There's allogeneic, which is from somebody else. And those are just two doctors, medical terms. And again, you got to be careful here. You want to make sure, again, the FDA doesn't really regulate whether you use these things. It just, as long as you don't manipulate them. And that's the biggest thing we talked about. You don't want to over manipulate these. And manipulation means like doing stuff beyond the machine's process, like trying to add other factors in that no one talked about. You didn't consent them for that. And again, we don't do that. And a lot of people, I don't know anybody that does, but it's just important for people to understand. So everything we're talking about is your own body. There are people that do stem cells from amniotic fluid and things like that. We are not talking about that today. There is not a lot of data on that stuff, so you just got to be careful, and it's incredibly expensive. So I want you to go to the next slide. So again, this is a really good. I always have to quote the studies from this. This is Rodriguez and Merkin et al. 2021. But this is really good for patients to see this. So these are reconstructions, and these are the growth factors that they're currently looking at. So they're looking at growth factors, stem cells we talked about, bone marrow aspirate, autologous tissue, pharmaceuticals, and there's different types of things. So go to the next slide. You'll see what we're kind of going at. So these are everything that people are currently looking at. And so if you want to ask what biologics are looking at, we're looking at everything. BMP growth factors is basically that putty we talked about. So can they add that and make people's ligaments heal harder to bone?
Yeah.
There's a bunch of other ones, fibroblastic growth factor. I'm just going to go on and on and on and on. This TGF beta is really important. And there's been some studies that can you add it back and help people heal their ACLs better. So, again, this is going to get a little boring. So I don't want, people ask about biologics, but then there's a lot of information in the background because you can't just throw in these potions. You got to look at the data, see if it's safe. VEGF is one that we hear about. The problem with VEGF is it increases blood flow. So is that, we see VEGF actually in cancers. So you want to make sure you're not just throwing that into people and causing more vascularity in an area. And then you've seen PRP. This fibrin clot's really interesting. So the idea behind it is you actually make these clots. But again, it's the idea is, can you put the fibrin clot or have PRP in some sort of gel form and then bring it in the knee? It's a conduit, right? Like if you just inject PRP into the knee, it might help with some anti-inflammatory properties like for arthritis, but is it going to stay where you want it to stay? So you have to have a conduit to get it in there. And the fibrin clot's nice because that's a thicker modality. So it's important for people to hear this and understand, what each of these things means. I think we probably can get off that. That's good. I don't want anybody to start yawning on us. So,
no, it's good. And if anyone's listening on the podcast, please check us out on our YouTube page. We have some slides. We have some information. The negative is that you're going to see our faces. But besides that, we've got some really good information here. So please check out our YouTube page. All right, let's talk about this PRP there. Go ahead, buddy.
When we talk about the PRP, I want to go back one more thing, though. Go back up to that other slide real quick. So there's the DBM putty you keep bringing up. So the idea, they've looked at this, and they looked at this with how does it combine with grafts from animals, because a lot of these studies are in animals. Yeah. They looked at different factors. Can you add the PRP and then add, a collagen scaffold, and can you apply it? And they've seen in models of rats and rabbits that if you add this DBM putty, it increases the tendon to bone healing. So again, the key is to soup up the healing so that your tendon that's in the tunnels closes off with bone quickly. One reason that's good is because you can hopefully stress it sooner. But the second reason is some of these grafts, like a quad or a hamstring, they're soft tissue, so they can windshield wiper. It doesn't happen usually in the short period, but one reason, if you get the tunnels healed faster, there's less likely chance that they'll get bigger. And when they get bigger, you can imagine what happens when they get bigger. They can get looser.
Right? Looser.
Or looser. And so you don't want that. Again, not that common if done well, but if the tunnels are off and you don't have them healing fast enough, they can cause a little wiggle factor.
What do you mean by tighten quickly? Like, what is that timeline? When these are kind of like, hardening and, it's getting set in place. What's the timeline from when you're operating? Are we talking a week, 2 weeks, 2 months? Like, what's the process there for that healing for it to get hard?
Depends on the person. 6 months to a year, and maybe more. Okay. And so that's why people aren't ready to go back yet. And sometimes we don't know. I mean, we're not getting MRIs and CT scans of everybody. I mean, like, you're ready to go back. Does that make sense? Yeah. And so that's something to be aware of. So the idea is, like, can you give them this thing so you boost them, and then you let them go back faster, and knowing that they've healed faster, or assuming. But we deal with fractures all the time. I told you I do these osteotomies or realignments. Last week I saw 3 patients back. They were all within 5 years of each other. One patient was 50% healed. One patient was 80% healed, and one patient was completely healed. Exact same surgery, exact same surgeon, within like 3 weeks apart.
And what were the age of the patients?
45, 50, 52. Okay, I'm talking about like literally everything the same. So we don't know how can we make one better than the other. But
I
maybe
got
that patient that was a slow healer, if we had known that, we would have added some stuff. So can we make them all the same? Can we get these patients back? That's another thing to be concerned about. Obviously, Chad Lavender's patients were really young, right? But the average age of an ACL tear now is like 27 to 29. And I would say that's pretty common. Like I do a lot of young kids, but I also do patients in their 30s, 40s, 50s that have ACLs that want to get back because there's lots of data they do well too. And so it's important to understand that as patients get older, they don't heal as fast. And so would this fertilized ACL work on 40-year-olds? I don't know. Would they be able to get back in 6 months? Would they even care if they get back in 6 months? Because everyone can say that I really want to get back in 6 months, but like these patients from Marshall, they're, high level athletes, right? Like 3 or 4 months for a pro athlete's great, but does it really make a difference for a recreational athlete? Like everyone wants to be back faster, but does it really make a difference? Now, sorry, keep going what you're doing and I'll add my last piece.
No, yeah, because I'm about to ask you something about when it comes to the age, right? So I'm just going to jump the gun. So try to remember what you were going to say. We're talking about the ages, and we talk about the biologics, especially of each individual, right? And if you're a baseball fan, one of the biggest stars in baseball got hurt again, Ronald Acuna, and he tore his ACL in his left knee on May 26th, right? Before that, in 2021, tore his right ACL. So now he's torn his left ACL. In 2021, he tore his right ACL. 2018, he sprained his left ACL. So between when he was 20 years old and now that he's 26 years old, he's had 2 ACLs and a sprain, both ACLs on each knee. So, is it something that because of the ACL, maybe other things weaken, or it's just sometimes just your body and the way you hold up and are able to just deal with the rigors of life, right? Every body type is different. And that's why I'm kind of bringing this in when you're talking about the comparison, the 45 to 50 to 53-year-old, same procedure, same everything else, different results. Is that an example, or is it a little bit more to it?
No, that's an example. There's some patients that just are higher risk, right? Like, I mean, I did two ACLs today, and both patients had ACL done on the other side. So it's just some people are higher risk. I mean, once you tear your first ACL, the second ACL is 6% risk on the other side, just from the idea that you've already had one ACL. It's actually higher risk to tear your ACL on the other side than it is to re-tear the ACL you just had done. So think about that.
Yeah.
So and that's what happened with him, right? Like it's just some people are at higher risk, and there's anatomy issues. There's, it's higher in females. It's the way they land. And again, he's male, but it's the same type of thing. One of the patients today was male that had other side done. So it's just, people are at higher risks, and it's the key is, can we identify those risks? I mean, we're going to do as much as we can, and we'll, I'd like to finish up this part. We're doing as much as we can to prevent people from having re-tears. And there's lots of things we talked about, adding the internal brace. Can we add biologics? Can we do some fertilized option to help them not have that issue? What a IT band tenodesis? Like, can we add all these other things so that they don't have that happen again? And now we're digressing, but the idea here is what you're hearing about is, and what patients want is, I don't want to do this again. I want to do it once. I want to do it right. I want to make it perfect. Well, it's never going to be perfect, but can we make it right? And can we give you a better shot than you currently have? Which is what we're doing here. Oh, I did it. I got it. So it must be this or something doing that. So
I think your daughters are sitting in another room with your wife, and they've got some kind of remote control or something, clicking on the button, the balloon button.
So yes. So anyway, so that's the idea behind this is, can we let people a leg up? So with the PRP, you can bring that up. We'll go through that quickly. They looked at this for adding, PRP. Again, this take your own blood, and then this is injecting the knee. In a surgery, you'd add it into the ACL, and there's different conduits that you can use this through. We've talked about this, adding putty, adding collagen, you name it. And so they showed in this one study that there were like 109 knees, 101 patients. So they obviously, some people were bilateral. It's a Burtis et al. And they had a lower re-tear rate for the younger patients that had the PRP collagen matrix added. Now, again, one study, so be aware of this, but there is a study showing that there is improvement. There's also a study showing that maybe these people, this is Vogren et al., and that some of these people that got the PRP, a different study, that they maybe had higher blood flow into the ACL graft. So again, you're getting the ligament turning into ligament faster, hopefully. And then again, sort of like a VEGF, which is that blood flow thing I told you about, but obviously a different type of material. Yeah. And some of these are gels. So they're PRP that's in a gel. You can see that that's actually what PRP looks like. It's maybe usually not that exact color. So, but it's usually around that color. And then can you put that into a gel so it just stays there and resorbs? Like it's like a time release capsule, right? Like you've seen medicines that are quick acting, but you want, in this case, you want something that's slow release. So this is another option. There is some data on it. It's just not really good. And I don't routinely offer this to my patients. If patients really wanted it, I tell them, I'm happy to do it, but obviously it is also an added cost. So, we're not there yet, but it's just some interesting information. Let's briefly bring up the BioBrace. I think it's important to see it. I don't want to overdo this. So this is a relatively new implant. It was designed for a lot of things. You can see rotator cuffs here. You have this idea. So the idea behind this is it's another collagen reinforcement or microfilament. And then basically what it is it's got a strength modulus to it. So it's like an internal brace type of thing, but it's supposed to reabsorb with the tissue. And people are doing ACLs with this. And actually my patient.
What do you mean reabsorb with the tissue? What does that mean?
It's supposed to grow in with the tissue and add some structural basis to it.
I got you. So it stays in. Okay. I got you.
Where it has really been helpful is in hamstrings. So in hamstrings, people take their hamstring tendons. They're generally smaller than the average ACL we do. And in under 25, we've seen less and less people recommending doing them. So the idea that we used to do is if the hamstring wasn't big enough, we would add cadaver tendon to, right? So it would make it bulkier. But now what people are doing is they're adding this BioBrace to it to make it thicker. The problem is obviously it's expensive. So it's not, everyone might not be able to get it. But the idea is that there's good strength, and they've been seeing that the goal is if you can get these hamstring tendons, like imagine, we're going to get too off topic, but basically if you take a tendon, imagine the width, you want the width of a tendon, the width of your tendon in your ACL to be bigger than 8 millimeters. But if you take a small girl or a small woman, a lot of times it's smaller than that. It's 7 millimeters. So how do you make it bulkier? Well, this is a biologic that you can add with some soaking of other biologics, and you can add it right into the ACL. And there's some idea that we haven't seen it enough. Most of the articles on there are not actually studies, but basically they're showing techniques how to do it. So we're not there yet, but there is some future hope for this potential option for patients.
Are you adding anything to this implant? Like, are you, coating this in something or coating it with, putting a PRP on it before you put it? Like, or is it just kind of going in there? Is this something that you can add to it as well before putting this in?
Yes. I mean, you can add like PRP, you can add bone marrow, and a lot of times you just basically integrate it into the graft. So there's certain suturing techniques you can use as well. You don't really need to add much for this because it's really its own thing. And so again, the idea is, how does this going to enhance the strength of our graft? And especially one of the highest risk you are tearing your ACL is between 3 and 6 months. And so by adding this, can we prevent that from happening? Right. Again, it's not that common. I mean, I can't think of anybody on my head of my patients that's torn their graft at 3 to 6 months. But like, the reason is they're also not going crazy, right? But Chad Lavender's patients are going nuts at 3 to 6 months. So that's the other issue. So can they go faster? And then therefore they've got this backup tissue. So we're attacking these things in really good ways, and we're going to get there, but we're just not there yet. I think let's kind of skip over this last one for the sake of time. But basically, the last thing is allografts. So we've talked a lot about your own tissue, right? Like there's hamstring, there's quad, there's patella tendon. But some patients, it's not an option. They I had a girl that's she's 24. She had 3 failed ACLs. They took every single piece of her tissue. So you got nothing left. So what are you going to do? Well, how can I make it better? Well, there's some studies this is in sheep, but again, using cadaver tendons, combining the BMAC, bone marrow aspirate,
Yep.
and the PRP, and they did see some improved incorporation. Again, just a sheep study. And there's some ideas also looking at, can you add this sort of, this is bone marrow, so you get it from the hip, you get it from the knee. Now here is AVN, so they're injecting it into the knee to kind of help it heal, but you can see other ways you can do it. We can take it from the crest here. This is in the back. And the idea is that they've seen that, hopefully maybe the tunnels won't get as wide with these cadaver grafts. Again, it depends on the type of cadaver graft you use. I use exclusively patella tendon, so it comes with bone on both sides. So the idea is behind that is there's no concern for this windshield wiper. Remember I told you about that, where it goes back and forth, back and forth. But a lot of people don't use that type of cadaver graft. They use something else that's got tendon on both sides. So if you have that, you have to get it to heal faster. And how do you do that? Maybe you add something like this. So there's a lot of minutia you got to think about when you talk about this, and be careful you're not comparing apples to oranges, right? So this was done on probably soft tissue, which is what we talked about that I don't use for allograft. So it may not be compatible for someone like me. And the way I'm doing it may be different or may heal better or worse. We don't know. I've had good results with it, but it's important to understand that everything is a little bit different. And there's so many caveats to this, but also ACL is we'll go into this. We'll just talk about this very briefly, but ACL is a really good surgery. It's definitely not perfect, but they're some of my happiest patients, and they get back to things they want to do. Again, not perfect. There are patients that don't get back to the sports they want to do, but it's also really popular surgery because it's really common. One of the most common surgeries I do is ACLs, but it's just hard. You got to be careful, right? Like you never want to do a surgery for an ACL kid and then make them worse, right? Like that's the most horrible thing you can possibly do, because these are not like, is it like you get your second and third and your fourth within a couple of years? Like that's not a good thing for you. Like it's not like you just go redo an ACL and it's no big deal, right? Like it is a big deal, even though it's obviously not life-threatening.
It's not cool. Those, none of it is.
So let's talk about this last topic. So we've gone in a lot of biologics. We've talked about a ton. I mean, this could be like a 3-hour show if you're seeing.
Well, we got 2.5 minutes left.
Well, let's talk about the last piece.
Go ahead.
It's all well and good, but one of the concerns is like, how do you why are things not healing as fast? Well, some studies have shown that basically the reason things don't heal as fast sometimes is there's an indolent infection. So like people will tell you like my graft failed at like a year. And thankfully I haven't had those issues, but that can happen. I've heard about it. And one thought is that maybe the graft, the thing you put in had a little bit of infection in it, but not bad enough to cause a real infection, right? Like it's a subclinical, like you don't notice it. And as a result, that the graft failed. Or over time, after 2 to 3 years, all of a sudden you get an MRI and then ACL's gone. Like, how did that happen? The patient never felt a pop. So did it dissolve from the infection? And so what we're doing now, for every single ACL I do, allograft, you name it, I wrap the ACL in something called vancomycin, which is an antibiotic. And there's been studies that show it drops the infection rate to literally 0. And I'll knock on wood, I have not had one. An infection after an ACL is an absolute devastation. And you never want that. So the thought process is not only, and like it's great to prevent the big one, right? Like I never want that to happen.
Yeah.
It's pretty uncommon, but these indolent infections, there are some thoughts that are way more common. And so can I improve their healing just by wrapping their ACL in antibiotics? And then yeah. So we're already doing
felt like you left the big one for the end. I mean, that's amazing.
Well, I think the problem here is that patients are so worried about getting their ACL better, they don't realize we're already doing a lot of things. And so the problem, I think, is I just told you a lot of really sexy, awesome stuff, but then we've got to start executing on it, right? Like we've got to, once the data comes out, you got to push it, right? Like if my bear patients are getting the same surgery as my ACL tightrope, but my ACL tightrope patients are allowed to go back at 5 months and my bears are making them wait till 9 months because the FDA protocol, am I doing the right thing for my patients with the bear? So.
Yeah, it's if you're going to tell people that you're reducing the chance of infections and that after this is one thing less to worry about, that's a big one because that's obviously a main concern. Yeah. Oh, it's that time, Dr. Garcia. I mean, we're going to wrap it up here. This was a great episode. So happy. And check us out at sportsdoctalk.com. We've got a lot more information, a lot more stuff going on. We really appreciate everyone listening to the show. Thank you very much.
Thank you.